All right. Well, welcome everyone. Thanks for being here on a Thursday morning and on Zoom. I'm Mary Alice Scott. I teach in the anthropology department at New Mexico State University, and most of my community work that's kind of part of what I do as an anthropologist has been focused on graduate medical education, particularly family medicine education. So I also work really closely with the Southern New Mexico Family Medicine Residency Program, as well as the New Mexico Primary Care Training Consortium. And part of the work that we have been doing is to really think about health equity and how do we teach about health equity, not just about the concept of health equity, but how we can really work towards seeing health equity happen in our communities. And so Athena and Ned and several other people from the coalition invited me to give this training that I actually received a version of this several years ago from an organization called the Structural Competency Working Group. And so this training has started out focusing specifically on working with people in health professions education. And the group that I work with has really tried to expand this beyond that and think about how community organizations might also be able to use this model to think about how we do work towards health equity. So that's what I'm going to be presenting today. And thank you all for just one more time. I think a couple more people have joined. We were having a couple of issues with the Zoom link at the beginning. So instead of having everyone introduce themselves individually, we're asking people to just introduce yourself in the chat. This looks like a really great, diverse group of people who are going to bring a lot of different kinds of experiences to the table. So I'm really excited about hearing what you all come up with in the second part of this workshop. But to give you a little bit of an overview of what we're going to be doing today, I'm going to start out with an overview of this concept, structural competency, and talk about what that means and how we have used it in our community work. We have a couple of, or we have a vignette as an example that we're going to be working with throughout the 2 hours that we have together, that's focused specifically on someone who has experienced substance use disorder. So we're going to kind of take a look at that vignette together. And then we're going to break out into small groups, and we're going to spend about 40 to 45 minutes in small groups, really talking about the interventions, the types of interventions that I'm going to describe in the first part of this workshop. And there's some specific questions that you all will be discussing. And then we'll come back to the large group and report out. And then I'm hoping to leave the last about 15 minutes of this workshop for folks from the coalition to be able to talk about where we go from here and what are the next steps in terms of the work that you all are doing. So that's kind of the overall plan for today. So I do have a PowerPoint, so I'm going to share my screen. And I think I mentioned earlier, maybe before everybody got on, this will be sent out to you afterwards. So if you would like to have access to what's on these slides after, you'll be able to have access to that, in addition to the recording of this workshop. So I'm going to go ahead and just get started. So we're talking today about using this structural competency framework to think about how we move forward in creating more equitable communities, particularly as it relates to health. But you'll see health is a very broad concept within this framework. So what I'm hoping that we will be able to accomplish by the end of this workshop or this training is that you all will be able to describe the structural competency framework. You'll be able to identify challenges, barriers, and strengths in achieving health equity in the communities you work with. And then that you'll also be able to create multi-level strategies that build on the strengths that you identify to be able to address the challenges and barriers that you know exist. I will also say at this point that like I said, this training, the original version of this training was developed by the Structural Competency Working Group. They have a website with all of their training materials available. So if any of you are interested in doing this training, those materials are available. You can also use my materials, and I'm happy to talk with everyone individually, at a later date if you're interested in this. But just so you know, this is something that the working group has decided to just make available, freely available, publicly available, so that as many people who want to engage in this framework can. Okay, so let's start out with what is structural competency. This term actually makes a lot of sense within medical education, which focuses on training in specific, what they call core competencies, but it doesn't often make sense outside of medical education. So we have kind of redefined structural competency just a little bit so that it's applicable outside of just medical education. And so the way that we talk about structural competency is that it's the capacity for health professionals, communities, and governments to recognize and respond to health outcomes as the downstream effects of broad social, political, and economic structures. So I'm going to break this down a little bit. So let's talk first about what we mean when we say health outcomes. And when we talk about health outcomes, we're really talking about the patterns of disease and illness that we see in our communities. And often we're looking at the unequal distribution of those patterns. So today we're going to be talking about substance use disorder. That health outcome is more prevalent in some communities than others. And we see different rates, right? Say across the United States, or even across one city or one town or one community. And that's kind of what we're talking about when we talk about health outcomes. But within structural competency, we also see health outcomes as downstream effects. And so what we're saying there is exactly it's an outcome, right? And so there are reasons why that outcome is happening. And so within the structural competency model, we want to focus on what those reasons are. So the health outcomes are a result, right? They're the end of the process, right? And we want to see what's happening at the beginning. And we assume that a lot of what's happening at the beginning has to do with our social structures, with our political structures, and with our economic structures. So we're thinking about things like what policies are in place in our communities that may create barriers for people to get access to services, for example, or what is the availability of jobs in a community, and how might that impact someone's ability to access a living wage, right? So those are the kinds of structures that we're talking about. Our political system, right? So how are we able to engage with our political systems, whether that's through voting or other ways of interacting with governing bodies or political organizations, and how does that impact the voice that we have in being able to make larger structural change? So that's kind of what we're talking about. So let me pause there. Does anybody have any questions or comments? If you are familiar with this concept and want to add anything that would be helpful, please feel free to do that either in the chat or unmute yourself, and I'll give that just a minute or two, or a minute maybe.
I don't know if you're going to address this. Maybe it's a larger concept, but my impression is that one of the largest determinants of health outcomes is your zip code, which affects all of the things I think you're probably going to be talking about in a few minutes. So it's where a person lives that affects a lot of this stuff. Yep,
absolutely. And we can think about I think that's a really good way to think about it, right? And I think there was a study, I believe there's a TED Talk about this, and I apologize, I cannot remember the researcher's name, but if anybody knows, put it in the chat, who did a study, the original study that demonstrated the impact of zip code over genetic code, right, or genetic makeup in determining health outcomes. And so, yeah, so we're talking about, that's exactly what we're talking about, the structures, right? Do you have sidewalks? Are you close to a grocery store? Do you have parks in your community? Are there places where people can get together to socially support each other? All of those kinds of things are really important when we talk about the structures that impact, that are the upstream causes of those downstream effects, of the health outcomes. Anyone else have questions or comments at this point? Okay, well, feel free to put things in the chat as we go if things occur to you or you'd like to comment on anything, or also raise your hand if I'm in the middle of talking and I can pause and call on you. I
Googled that TED Talk and put it in the chat. It is Anthony Aiton, I believe.
Thank you. Yes, that's exactly the one I was thinking about. Thank you so much for doing that.
Yeah, for sure.
Yeah. All right, so I'm going to keep going. So I want to stop talking for a minute and share a video, very short video with you that I think does a really good job of demonstrating what we're talking about when we talk about structures. So I'm going to stop sharing for just a minute, and I'm hoping this is going to work. I think so. Oops. Okay, are you all seeing the full screen video? Yes, okay, all right. So it's just a few minutes, but see if you can identify the structures.
Not playing on my end.
Nights across infinite desert plains, showing signs of endurance and bravery I could only dream of emulating. He would tell me that upon their return home, these warriors would be welcomed with a feast worthy of their bravery on the battle. Years later, as a teacher in Greater Washington, D.C., I too now find myself traversing a desert, though it is not the one I envisioned. A food desert is categorized as a poor urban area where residents cannot afford or are not given access to healthy foods and grocery stores. Every day at 2:45, I watch my students hop onto this leaking submarine of a school bus, every block bringing them deeper into an ocean where the only fish they find are fried, where fruits and vegetables just can't be found because there are no grocery stores here. Just liquor stores and Popeyes, Dunkin' Donuts and 7-Eleven's, children born into a neighborhood that feels more pollution than solution. It is then I realize that I am not too far from the deserts I once dreamed of. See, whether Anacostia or the Sahara, it doesn't make much difference because to Whole Foods, Southeast DC is no different than the Serengeti. To them, brown-skinned little boys like my students are nothing more than walking cacti, just a piece of scenery this world has taught everyone to stay away from. Rihanna literally has a landfill in her backyard, so she has a hard time.
Dr. Scott, we can hear it, but it just kind of stuck on. Well, mine says you started screen sharing, but it's stuck.
3 steps from her back door, Jose. He's back 5 days a week because his mother works 3 jobs to take care of 6 kids and only sees her son when she arrives home from work. At the same time, he's leaving for school. He has got so big that the excess fat bunkered beneath his skin puts added pressure on his joints and knees are literally crumbling under the weight of this world. Olivia watched her father shot 2 feet from her front porch. She wants nothing more than to go outside and play at the park after school, but gun violence has made a merry-go-round feel more like Russian roulette, so she doesn't go outside. Simply eat any.
I think there might be a glitch within Zoom because I can still hear the audio. From leaving the house oh, there it goes.
These are my students, my warriors, fighting a battle against an enemy they cannot clearly see. These kings and queens meant to feast, not to fester, but their zip code has already told them that their life expectancies are 30 years shorter than the county 7 miles away. I can see the faults of my own ancestry shaking in their eyes. Diabetes and high blood pressure run through the roots of my family tree. Heart disease is as much a part of my history as shackles and segregation. So from my father's kidney transplant to Olivia's asthma, these things are more than mere coincidence. Both grew up in places more accustomed to gunshots than gardens, so tell me place doesn't matter. Like the neighborhoods that are predominantly healthy aren't the same ones that are predominantly wealthy, because when you're not choosing between buying your medicine and your groceries, health doesn't have to be a luxury, doesn't have to be an abstract concept presented in academic journals and policy briefs. My students overcome more every day than I will in my lifetime. They are the roses that grew from the concrete, the budding oasis in the heart of the desert, and their lives are worth far much more than the things that this world has fed them.
All right. I don't have, people may have seen that before. Clint Smith is a poet and a high school teacher in Washington, D.C. I'm not sure if he's still a high school teacher in Washington, D.C. This video is like from 2013, I believe. To me, that just really gets at what we're talking about when we talk about structural competency. So before I move on to our specific vignettes that we're going to be talking about today, did anybody identify some of the structures that he was talking about that impact the health outcomes of his students? And apologies for not being able to see the video at first. Yeah, food deserts, right? And that food deserts happen often because of the particular policies that are in place that make it worthwhile or not worthwhile for a grocery store to locate in a particular community. It's related to income of that community as well. Yeah, violence or gun violence, right? That's more concentrated in some communities than others. That has to do with many different structures, policing structures, income in communities, and that kind of thing. Let's see, you talked about health outcomes like asthma, which we know impacts some communities more than others. Landfills, pollution, right? So some like when decisions are made, for example, on where to build highways, those are often, new highways are often built close to lower income communities. And those highways, when they're built, increase the air pollution in those communities. And then you start seeing health outcomes like asthma, especially in children. And Jessica said he also mentioned roses growing through the concrete. So thinking about like urbanization and lack of parks and lack of green spaces, that also illustrates some of the strengths, right? And so in the sort of towards the end of that video, he talks about how strong his students are, and that we should be supporting them, right? And helping them develop and grow. Someone else mentioned lack of medical services. Yeah, why are there medical services located in some places and not in other places, right? So starting to think about that will help us get at those structures. All right. Well, thanks. Great. Let me go back to the PowerPoint. Let's see. Okay. We also, so what we're talking about today is that health disparities are often caused by poverty and many other types of inequities and structural issues, like structural racism, like gender inequality. Those contribute to health disparities. And what we want to think about is what are the things that can influence poverty and structural racism and other kinds of inequalities that we're seeing. So we want to start thinking about what policies support or sustain those kinds of inequities. What kinds of economic systems are we talking about that may be sustaining these inequitable systems? What kinds of social hierarchies exist, right? So all of these are the structures that we're talking about in structural competency. So it's a lot to deal with, right? But we're going to work through it. We're going to work through it together today. So what I want to do now is to talk about a specific story. And Ned, please feel free to jump in on this story since this is one that you know quite a bit about. We're going to tell the story backwards. So this is the story of an individual person and kind of what happened to her as she went through her life. Now we're going to start.
Let me just say one thing that
Sure.
This story is drawn from my wife's agency that she managed for almost 30 years in Milwaukee. She's here sitting, knitting, and listening carefully. So she may have some details to add as we go along. So I just want to let you know that this isn't something made up out of whole cloth. This is a real person whose real life is being reflected here.
Thank you. So, and please jump in. So I just learned this story a couple of weeks ago. So this is a new story to me. So I will really appreciate both Ned and Francine's input as we go through this. But like I said, we're going to start at the end of this story. And so this story is about a woman named Marcia who, and I'm going to say it wrong because Maida House. Maida? No. Yes.
Well, how do you say it? Maida. It's actually, it's a woman's name.
The woman's name.
Her first name was Maida.
Okay. So, so at the end, well, the point in the story where we're starting is Marcia entering Maida House, which is a residential treatment center for women and their children with substance use disorder. So how did Marcia get here, right? This is one of the ways that we kind of think about how we can sort of conceptualize the structural competency framework. We start with the health outcome, right? She has substance use disorder. She's struggling. She's entered treatment, right? So how did she get there? So the immediate reason that she's there is because she was referred through the court system but how did she enter the court system, right? She'd been arrested and convicted multiple times for theft, sex work, and some felonies. Okay, so how did that happen, right? Well, she had 3 children in foster care, and she was really struggling to try to figure out how she was going to kind of organize her life so that she could regain custody of them. She had graduated from high school, but she really had limited skills for the workforce. So she was really having a hard time figuring out how to make all this work. And before she graduated from high school, she'd really not been able to focus on school very much. And so even the skills that she could have learned in high school were even more limited for her because she just really wasn't able to focus. So why was that? Well, she had been during high school also using petty theft and sex work to pay for alcohol, marijuana, and opioids while she was in high school. So, you know, she's dealing with a lot. Focusing on school is not necessarily going to be a major priority. But why was she doing this, right? What were the reasons that this was happening? Well, she had been introduced to alcohol, marijuana, and opioids during high school by her boyfriend, and she said that it was kill the pain or kill myself. So why was she in that kind of a situation where those were her choices, right? Well, her parents divorced when she was 10 and she had gone to live with her grandmother. So why did that happen? She was sexually abused by her father, and her mother was physically abused by Marcia's father, and her father was using substances. Okay, so where did that come from? Well, Marcia was born in the central city of Milwaukee, which from what I understand, and Ned, please let me know, is a very segregated city. And so living in this part of the city, already born into a community that lacks access to a lot of resources.
Actually, Milwaukee is one of the most segregated cities in the country.
Okay.
Redlining and all that stuff. There's a lot of historical reasons for that. I suppose that's one of the social
It's one of the
issues
structures, right? And so also Marcia is Black. And so she lives in a community that's largely Black and African American, and is in this very segregated city. Okay, so before I get to the structural pieces, what else this is like a simplified version of Marcia's story, clearly. Is there anything else about Marcia's kind of early life that is important for us to know, Ned and Francine?
Let me unmute myself here.
Her mother, you've got that on.
Yep.
Her mother was actually a nurse, and her father was a carpenter, and they were married, which I think is important to know, because while they lived amongst poverty, they did not live in poverty, at least not till she was 10. So I think that's, an important thing to know. about her as well. The other thing about her that was kind of very interesting was that to speak with her and to read her writing, you would think that she just wasn't very bright. I don't know what else to say, but I am a psychologist and I had done some testing and she was actually very bright. So, you know, she had that going for her, although she did not perceive that in herself, and nor would you perceive that if you had met her.
Great, thank you for those additions. And so right now, this story is individual, right? This is a story about Marcia. But Marcia is part of a group of people who have very similar experiences, right? So you all may know people who have had similar experiences. You may be someone yourself who has had experiences like this. And so what we want to think about in the structural competency framework is, why did this happen? Why did this story play out this way, right? And so I have a few examples, and I will definitely ask all of you to add some additional ones. I'm limited by the room on the slide, so there are plenty of other structural factors that we could consider here. So let's start at the beginning. Structural racism causes segregation and concentrated poverty in an inner city, right? So even though Marcia's family wasn't necessarily living in poverty at the beginning of her life, this is the community that she lives in. And so she has a similar lack of access to resources based on where she lives that other people in her community might have, right? And before I go on, I think one example is, as Ned brought up, redlining. And so this is a historical practice where banks who would give mortgages for home loans actually drew red lines on maps around communities where loans were riskier. Those communities were largely Black and African American communities. And so people couldn't get mortgages or home loans in those communities. That caused a historical lack of investment in those communities that has led to now there's, limited economic opportunities. The quality of housing is often poor because people haven't been able to invest in their own homes. Businesses don't want to relocate or start branches in the communities because the income has stayed really low because there's just been this historical lack of investment. And even though redlining is now illegal, it continues to have an impact on communities. And so that's structural, right? That's what we're talking about. So the next example of a structural issue is that we have limited resources for substance use disorder treatment, specifically for women and those who are experiencing IPV or interpersonal violence. And that has to do with policy too, right? There's a focus in policy and funding on punishment for substance use disorder rather than a focus on treatment for substance use disorder. And so we see that playing out in our communities. I know you all know more about this specifically than I do. So if anyone would like to comment on that specifically, please do. Another structure, go ahead.
I'm just going to say limited resources also means people who don't have access because they don't have insurance.
Right, absolutely.
So there's the community availability, then there's the individual's ability to access what may be available.
Right, absolutely. And insurance, right? That's related to policies of, who can get insurance and who can't get insurance, or which insurance you can get, right? Because some insurances may cover treatment and others may not.
Language barriers. I mean, here down in the southern part of our county, we don't have to go very far to unfortunately get a lot of examples of this situation. So that's just a whole other dynamic with the language, et cetera, et cetera.
Absolutely. Absolutely. Yes. So, yeah. And again, these are structural issues, right? Another structural issue is underfunding of community resources, which then limits other options available to young people, right? So if you don't have support for young people in your community, then there may not be any place for people to go, early on when they're struggling or they need help or they need support. And that we see that not just with substance use disorder, but in a lot of other ways as well. And then we can think about school to prison pipelines, right? So again, this focus on punishment rather than treatment. And so Marcia in school may have been identified as someone who needed discipline or punishment rather than someone who needed support. And that can contribute. I don't know if that was the case in this particular case, but that's often an issue. So if schools are focused on punishment, so say, for example, suspension, out of school suspension, and other kinds of disciplinary practices that actually remove students from any kind of potential support system they could have, you're really not giving people the opportunity to be able to address some of the issues they're facing.
And this also speaks to the work that the coalition has done around trying to get universities and high schools to get rid of zero tolerance policies, right? Especially around substances. When you have somebody who's having some substance use, whether it's experimentation or a disorder, right? And then you cut that person off from all of the support they get through the school, that's, terrible.
Yeah.
Terrible policy.
Yeah. So we have lots of structures that are in place. And what we're going to do in the second part of this workshop is I'm going to talk a little bit about some strategies for interventions, and then you all are going to talk about how could we intervene, right? How could we keep Marcia from getting to the point at the end of this story? But the other thing that we're going to talk about is the strengths. Oops, that wasn't supposed to come. That was supposed to come up at the end. Oh, well, I revealed the end of the story at the beginning. But because Marcia actually did end up like doing really well. And a lot of it had to do with the access to treatment that she had. And so I want to tell the kind of other side of the story. And then we can talk about some of the structures that were in place that supported her, because I think the other thing that's really important to remember is that our communities and our organizations have strengths. And we really want to make sure that we're thinking about those and how we can build on those strengths to address some of the other structures that are more negative. So I'm going to go through this. And again, Ned and Francine, please add detail as needed. If we're going to go forward in this story, except you already know the end. So Marcia, like at the end of the other story was that Marcia entered Maida House and she with substance use disorder, right? And so while she was there, she received treatment that was coordinated with multiple other services and other agencies involved. So she had lots of services available to her and treatment options. Following initial treatment, she started to feel capable of making changes, right? She needed that treatment and that support to get to this point where she could feel capable of making changes. She learned skills that support her returning to school, and she does go back to school. She regains custody of her children while continuing outpatient treatment at Maida House. She earns a bachelor's degree. She begins actually working at Maida House as a certified peer specialist. So she now has a bachelor's degree. She has a job. She's able to use her lived experience, right, in the job that she has. She keeps going in school and she earns a master's degree. And then she gets a position as a social worker, case manager for the Milwaukee County Drug Court. And then continuing this story, she keeps supporting others who had similar experiences to hers. And in the end, and this happened recently, right, that she received a pardon from the governor for all of her convictions, which obviously opens up many more options for her because she doesn't have this conviction on her record. So Ned and Francine, anything else to add in this individual story?
I don't know how this relates exactly to the process here, but you were talking about access to treatment, and I think it's important to understand that the program that she was in was able to provide pretty much everything that was needed. It was not an insurance model. Okay, so she could stay in residential as long as the treatment plan drove the length of stay as opposed to who's going to pay. She also got her children back while she was in housing in our program. So we had a residential program. We had, excuse me, a day treatment or IOP program. We had outpatient and we had HUD housing for women and children. That was, you know, clean housing. It was sober housing. And there were, you know, just tons and tons and tons of services, including partnerships with child welfare, with TANF, with the criminal justice system. I mean, it took a huge amount of integration, and she was not alone. I mean, we didn't do this just for her. This is pretty much everybody's story. I think one of the biggest driving factors in all of this was actually the sexual abuse, the trauma, which was quite common among the women that we served. It pretty much drove everything. And, you know, maybe that's something we can talk about as well, but 95% of the women that we treated had histories of childhood sexual abuse.
My sort of meta observation of Maida House is that virtually all of the negative social determinants in Marcia's life were addressed in one way or another within this comprehensive program that Maida House evolved, which again was not determined by who was paying for this. This was funded by grants, so they had the opportunity to do this. Also, the pardon from the governor, just in case you're interested, came within the last 18 months. So now there's all kinds of things open to her because she no longer has to address this criminal record that she's had for years and years.
Yeah, great, thank you. So I want to talk a little bit about what are the structures that are involved here, right? Because we can have structures that support. Structures don't have to lead to poor health outcomes, right? They can lead to, you know, a fulfilling life and a pardon from the governor, right? So that can happen too. So what are some of the structures that we're talking about here? Well, one thing that Marcia had is that she had comprehensive services for substance use disorder. Now, I think we can talk about, you know, that it had to be funded through grants and it wasn't, you know, there are some limitations, right, to that. But is there, you know, are there other ways that we could think about having those options that would be available to more people and, you know, wouldn't require continual renewal of grants, right? But thinking about that, like that availability of comprehensive services made a huge difference, right? Another structural piece that we could think about is that Marcia, she had actually sustained support from courts and other involved agencies for initial treatment and her subsequent growth and development, right? That doesn't always happen. And so are there ways that we can think about what do our court systems look like? What do those other agencies look like in order to be able to provide support for people? And then programs that focus on reuniting families rather than punishment, right? So I think if you all are familiar with the foster system, you may be more familiar than me. So please, again, always jump in on this. But you know, there's a focus on separating people, separating children in the interest of protecting those children. But then that second piece of working with families to make it possible for children to reunite with their families is not always the focus of programs.
I also think it's so fascinating that children, you know, often get separated, certainly due to drug use and to, you know, poverty. So then they're put in a system where we pay the caregiver, the new caregiver, right, however much a month. I always wonder what a difference it could make to those families if we just paid that original family that much money. Yeah. You know, and how many problems that would solve, right? Yeah. Feels like parents are sort of, it's challenging. I am really glad we do have, you know, we're a little more progressive in this area in New Mexico, but I mean, still, you know, we have that history of indigenous families having their children taken away, and it's a big problem.
Yeah, thank you for that. And then I think one other structural factor that I just wanted to include here is educational opportunities for non-traditional students, right? And when I say non-traditional students, I mean students who aren't like 18 years old, just graduated from high school, kind of going on to college. And so students who maybe have had a bunch of life experience in between high school and college, or maybe, you know, didn't get the preparation necessarily during high school that they needed for continuing education, or maybe didn't graduate from high school and are working on GEDs. So those opportunities can be structural responses to some of these kinds of issues. Okay. All right. So I'm going to talk really kind of briefly, give you some examples of some levels of intervention, and then we're going to break out into small groups. But before I do that, is there anything else, any other comments anyone wants to make about Marsha's story?
I guess I just always like to make the point, structural competency for me echoes one of my favorite things that I'm talking about all the time that we, those of you in public health may have learned about, which is the health impact pyramid, which also is sort of like a way of saying, there's these different levels of intervention, and that levels of intervention that look at system change and economic change have the greatest health impact. And so I think that resonates right along with the structural competency framework, looking at the different levels of intervention and the different levels of impacts that we can have.
Yeah, thank you. Yeah, that's a great introduction to the levels of intervention.
I can add one other thing about Marsha,
Yes.
in case you're interested. Francine just spoke with her recently. She's currently celebrating her 53rd birthday on holiday in Jamaica.
Nice.
Nice.
That sounds fun. That's great. That's yeah. And I think, so what I would say generally about Marsha's story, first of all, like I said before, it's not just Marsha's story, right? Many people have either the first part of that, maybe just the first part of that story, but some people do have the second part of that story as well. And I think it's important to kind of think about the populations that are affected, people who have similar stories.
Yeah.
But the other thing to think about is, how can we think about intentionally intervening as far upstream as we possibly can? Maybe so Marsha never had to go to Maida House in the first place, right? So that these things were addressed much earlier on in her life. And so that's when, in order to kind of help us think about how we can actually intervene, because these seem like impossible issues, right? Like, how am I supposed to address structural racism, right? How am I supposed to address the historical segregation of cities, right? How am I supposed to think about these things? And so these levels of intervention help us think about where we can start. And so this is, if you all are in social work or public health or a related field, you may recognize this as very similar to the socio-ecological model. That's where it comes from. And it's kind of modified a little bit to fit the structural competency framework. So we're going to talk about 6 levels of intervention. And I think, as Athena mentioned just a few minutes ago, there's different sort of scope. There's a different scope of impact, right, with each of these levels of intervention. One is not more important than another, but I think you want to think about where you want to have the impact. Are you most interested in having an impact on a few individual people, or are you more focused on the policy level, right? So it's going to have a different scope of impact, but it's important, right? So if it's at the individual level, the individual people you impact, their lives will be changed, right? And that's important. And if you're working at the policy level, you may have a larger impact on a bigger population, which is also important, that impacts lives as well. So I'm going to go through, sorry, I'm checking the time. Okay, I'm a little behind. That's okay. I'm going to go through just some examples of what you can do at each of these levels, and then we're going to get into small groups, and you're going to talk a whole lot more about your own ideas for how you can do this in your own work. So at the individual level, this is really thinking about, okay, what can I do by myself that will have an impact? And so I think about things like learning, right? Engaging in learning, say, about implicit bias, learning about structural competency, learning about what structural issues your community faces. And then I think also about changing your own perspective. So, for example, avoiding moral judgments of people in your community, right? Recognizing that people are where they are for all kinds of reasons. And it's usually almost always not because they're a bad person, right? And so being able to reframe your own perspective sometimes can be really helpful at the individual level. And then when we move to the interpersonal level, we're thinking about what do you do in relationship to other people? So whether that's colleagues or friends or clients or patients or, you know, whoever you're interacting with. Someone brought up language earlier. And so this is a really good example, addressing language barriers. And that might mean needing to use interpretation services or making sure that your documents are translated into the languages that your community members speak. But it also might mean using language that people are going to understand, right? So, I, you know, as an anthropologist, you know, I can pull all my jargon out from anthropology, and those of you who are not anthropologists may or may not have any idea what I'm talking about, right? Same goes for those of you who are psychologists or social workers or working in treatment facilities, peer support specialists, right? Like all of us have our languages that we use that may or may not be understandable to other people. And so really thinking about whether we're actually communicating really with people in a real way that's going to be understandable is important. Something else is to really think about the power imbalances between yourself and the other person that you're communicating with, and trying to shift those when you can, right? So if I'm in the role, for example, I'm often in the role of teacher with my students. If I can kind of shift the power, there's going to be a power imbalance there, right? I'm evaluating them. But if I can shift that a little bit and say, hey, you all have things to teach me, then that can really change the dynamic of that relationship. And then I think, again, I'm using the generous assumption, like recognizing that there are all kinds of reasons why people may be responding in the way that they are to you, why people may be in the situations that they're in. So just trying to think about not blaming that individual person is really important. And then if we think at the institutional level, and here I'm thinking about the organization that you work within, it could be, you know, governmental agency, community organization, wherever you are located, right? And this is really about thinking about the policies within your organization. Are you creating unintentional inequities in the policies that you create? So for example, this is a clinical example that I've seen a lot. A lot of clinics will have these policies that if you're late for 3 appointments, you get fired from the clinic, right? That policy inequitably affects people who don't have their own methods of transportation, right? Who have to take the bus or who have to ride a bike or who have to depend on someone else to pick them up, right? They're way more likely to get fired from a clinic practice than someone who has their own car and enough money to pay for the gas, right? And so really thinking about, you know, that policy is supposed to be neutral. Hey, it applies to anyone, right? But it doesn't affect people equally. So that's an example at the institutional level. You could also think about restructuring physical spaces so that they're actually really accessible to everyone who you work with or you serve. And that could be, you know, the arrangement of chairs. That could be making sure that there are private spaces for people to be, if they, you know, if they need that, you know, whatever that might be. So there are a lot of different examples of that. And then the next level is community. So really thinking about how you create opportunities for your community to speak and to lead in your organization. That might be having a community advisory board. That might be, like in Marsha's story, hiring Marsha, right? To work in that place where she received services, because her perspective is going to be different than someone who never had received services or been part of that. Partnering with other community-based organizations who are working on the same issues you are, sharing resources and really thinking about how you can increase your impact by doing that rather than maybe competing with each other is another example. And I know I'm going through these fast, but I want you all to have time to talk. And then if we think about policy, you can contact the media, seek out other opportunities to publicly state your opinion on these structural issues in your community that can have an impact, right, on the policies that are made. Writing op-eds, writing policy position papers if you're in a place where you can do that. Developing relationships with elected officials so that they come to you to say, hey, we're working on this bill on this. Like, what do you think? Looking at the policies of your organization, again, that can also be, these levels are not mutually exclusive. So you could also be thinking about policies in your organization with like the example that I already gave. And then the last level of intervention that we think about in the structural competency framework is research. You don't necessarily have to do research yourself, right? It might be that you're using, and I say accepted forms of evidence just because you have more impact when people identify the evidence that you're using as reasonable evidence. I think we need to do some work on what kinds of evidence are accepted, because I think there's some evidence that we have that doesn't sometimes get accepted in policy circles. So I think that's another area we need to work on. But use that evidence to say, hey, here's the problem that we need to be addressing. Learn about, you can do research yourself, right? Learn about the histories of current policies like redlining, right? How did that happen? So we make sure we're not doing that again unintentionally. And keep up to date on current research in the areas of interest to your community can also be really helpful in just thinking about how you can design interventions that are going to be effective. Okay. So those are the levels of intervention. So what I'm going to do now, we're going to break up. I'm sorry, I'm not paying attention to the chat. Okay, currently having issues with breakout rooms. Okay. Should we stay in the large group and do a large group discussion instead?
Up to you, Dr. Scott. I don't know why Zoom isn't letting me do the breakout rooms. If you think it would take up too much time for me to end the meeting and have everybody restart, we can do a group discussion. But if, I mean, everybody's okay with just like, if I end the meeting and then everybody rejoins, please let me know.
How many people would end up being in each group if we broke up?
So there is 20 of us. And so since we have 5 facilitators, we would have about, what is that? I can't do math today, about 4 people in each group.
I kind of like the idea of staying here and having a large group discussion, but rather than rejoining, Ariel agrees, and it looks like Sankirtana has to jump off. So
So
I
if
like
you guys
the
are
large
okay with the
group
large,
idea.
you like the
Large
large,
group?
okay.
Okay, so let's stay in the large group. We've got multiple potential co-facilitators then in the large group. Okay, so we'll stay in this large group and we'll talk about these 3 questions. So I will actually stop sharing and I'll put the questions in the chat so you all can see them, but I think it'll be easier we'll be able to see more people, at least, hopefully everybody. Oh, they're posted. Thank you. So let me say before we get started, I like to say a couple of things about, I think, sort of ground rules for having group discussion. One is that if you're a person who tends to talk a lot, I would ask that you allow other people to chime in before you do. So give it a pause, take a couple breaths before you jump directly in. If you're a person who tends not to participate, I would invite you to jump in early because the people who tend to jump in early are going to give you a chance, right? So I would invite you to do that if you feel comfortable doing that. You can either unmute yourself or use the chat. Either one is fine, whatever you feel more comfortable with. And then the other, I think, main thing about a discussion like this is that we're all going to have different ideas and come from our own experience and different perspectives on how we would address doing this work, right? Of how we address intervening at structural levels. So we don't all have to agree with each other on what the best strategies might be, but I would ask that we all respect each other's experience and perspective so that everyone can be heard and we can really consider everyone's ideas. Does that sound okay to everybody? Okay. All right. And so we have the levels of intervention as well in the chat. Thank you for that. So so you can choose whichever level of intervention, since we're in this larger group, that it kind of resonates for you or that you think about first. And let's think about a substance use disorder in our community specifically, how might you intervene at any of those levels to address some of the structural factors, either the ones that we brought up in discussing the vignette or other ones that you can think of?
Okay, I'll go ahead and start. Can you guys hear me? Yeah, okay.
Yes.
So I would say on the individual level, definitely try to find out what resources are local. That could be as simple as just trying to Google to see what places are available for people to seek out either medical assisted treatment, and even taking a training such as this one today, I think is very helpful.
Great. And learning about what resources are available also lets you know what resources aren't, right? And so that can help you start to think about other interventions that might be needed as well. Yeah, that's great. Thank you. And that's kind of at the individual level. Are there any others at the individual level that people are thinking about?
Well, I'm thinking about using Marcia's case as an example. I was thinking about the court where the whole process really started with the referral to Maida House. It was an exceptional district attorney because she had been in court many times. It was an exceptional district attorney who decided to do something different than incarcerate her. So at the individual level there was some information that was provided to this district attorney that allowed her,
The assistant?
Yeah.
Yeah.
allowed her to talk to the judge and do whatever it was that ended up being done for Marcia. But there's larger levels, as you pointed out. I mean, the whole idea of drug court, I'm not sure really is doing the things that it was fantasized it was supposed to do. So I don't know if maybe that's an institutional level, the court system, and it involves having information to both the prosecutors and the defense attorneys, as well as the judges. So that's a much larger intervention. And even above that, there need to be policies that allow that to happen. So money has to go from the state and the feds to allow the drug court system to function. And now we have vet courts and we have mental health courts, so the model people seem to have grasped, but I'm still not sure if it's doing the things it needs to do. So that's just several levels using that sort of one person as an example, I guess.
Yeah, just so you know, there's no way the court would have done what they did, the DA or the judge, if it had not been a residential program.
Oh, she needed this particular kind of program.
Right. Well, not just needed it, they didn't want her on the streets.
Right. So a few thoughts.
Yeah, thank you for that. And I think that also demonstrates how these levels are so interconnected. So I think it's fine if you have an intervention that could fit in any of the categories. These are just, conceptual levels to kind of help you think through it a little bit more. Are there any that people thought about at the interpersonal level? Or any other one?
To kind of jump on what Ned had mentioned, also on that clinic institutional level, also even seeking out grant writers to seek those funds in order to create these programs.
Yeah. Yes. Great point. Thank you.
Yeah, just so you know, to run the program that I did, the budget at the time that I retired was $6 million. And we had 24 different grants, including what we billed for insurance and that kind of thing. And with 24 grants, you need a lot of administration to manage all that for many reasons, which I won't go into, but yeah. And I think that points to the problems with our insurance system.
Right. And that's a that's a policy level issue, right?
Mhm.
Of dealing with insurance. Yeah.
Could you
I
give
think
us
when we
another
think of it-
example? Oh, sorry, of interpersonal, just I feel like I'm like having some challenges parsing the difference between individual and interpersonal.
Oh, sure. And they overlap so much. It's really hard to kind of see the difference. So individual is something that you can just do yourself. So like Ariana mentioned earlier, learning the resources, right? Learning what resources exist in your community, participating in a training, right? The interpersonal is more thinking about how you interact with other people. So are there things that you could change about the ways that you interact with other people that would make a difference? So one example that I used was the thinking about the language that you use. So if you're not communicating clearly with people, and it could be clients that you're working with, it could also be the district attorney, right? In that example, right? If you're not communicating clearly, then you may not be able to have the impact. So really thinking about that as one example. Does that help?
That makes me think about being sure to use clear and non-stigmatizing language, avoiding things like dirty or clean, and rather saying things like positive or negative toxicology report, or you know, like free from illicit substances, or like something, you know, yeah, and encouraging people not to use or maybe modeling, you know, non-disparaging terms when people use disparaging terms. You know, I liked the way that yeah, the term addict, like that said, I liked the way in the vignette, right, you use the term sex work, right, which you know, is preferable these days to prostitution, or you know, other words that we might use for that. So you know, giving referring to people in your communication with others with dignity and respect, and advocating you know, for that in other areas.
Yeah, I think that's a great example. And in this particular, you know, talking specifically about substance use disorder, you know, there are all kinds of terms that get used, right? That stigmatize people, and that label people as somehow deficient in themselves, rather than identifying that the problems are structural. They're not with the, you know, the individual person.
Sorry, I think even when we use things like lazy, right, or like not motivated or non-compliant, or you know, those are all really stigmatizing terms, right? And thinking about, like, you know, why is that person non-compliant, you know, what, you know, why are you perceiving it in that way? And I think that goes along with what you were saying about having that generous viewpoint. You know, maybe the person can't engage in something because they're neurodivergent or learning disabled, or you know, this doesn't resonate with them, or you know, and so where are we not meeting the need, you know, or whatever.
Yeah, thank you.
Athena, I just want to add to what you're saying. You're talking about stigma, and just multiply that times 100 when you're talking about a woman that's a substance user.
Well, and
because-
especially when she's a mother, and then forget it
Right.
if she's pregnant.
Right, exactly.
Yeah,
Thank you.
100%.
I think where would mental health fall in? Interpersonal mental health. I think there's a lot. I mean, especially here in New Mexico, I hear in Milwaukee, but there's a lot of mental health. I'm a mother of a 20-year-old. He's got bipolar. In and out of the court systems, IEPs, all of his life. And I think, I mean, we say interpersonal, there's a lot of, I mean, it's interpersonal, it's structural. We're trying to get him into programs. There's a lot of waiting lists in a lot of these programs due to funding, I mean, or whatnot. The same with the JPO system, understaffed. So there's a lot of levels that need to be fixed. I mean, unfortunately, coming from somebody who lives it, you mean with a child, and and he's a male child, he's a boy, but from the day he's been in kindergarten, there's just always been something wrong from, different people, different medications. And unfortunately, now we're dealing with somewhat of a heart problem. That could have been one of the medications that we had him when at 10, 11 years old. And I think it's just been a whirlwind of things, but there's, I think, a lot of disparities that I've dealt with here. And being born and raised here in Las Cruces, New Mexico, had him at a young age. I was 19. And it just goes from there. So I've got a whole story to tell, of course, and we won't go my own personal story. But it's definitely a challenge, I think, just all the way around.
Yeah, thank you. Yeah, you're describing probably it's in some way every single one of those places that we need to intervene at every single one of those levels with that. With your personal story, which is probably also similar to other people's stories as well. So yeah, Jessica.
Yeah, thank you, everyone. So just thinking about Marsha's story, and I guess it really resonates with me just because I was born in Milwaukee and raised around Milwaukee area. So I know the city very, very well. And when I think about these levels of intervention, I think I'm probably thinking about in the intervention of community research and policy. That was what I immediately had jumped to in this aspect. And I've been thinking a lot about in Marsha's story that the substance use is connected to the abuse that she sustained in childhood. So at a community level, I think a lot about the intervention of counseling or education or support within the community, within the school system. Did somebody notice that she was being abused? Did she talk about it somewhere? Was she at school? Did she have any interaction? Was there any encouragement at school to talk to somebody about it? So I think about that community response, and I also think a lot about the community intervention of parenting types of supports and so forth. So I think about that aspect, and then I also think about the aspect of policy and research. I think maybe there's some interlap. I think about the criminalization of substance use and research shows that that's been detrimental, and policy. And I think it's getting back to what has already been earlier stated, is that there's just not enough approaches, funding, support, facilities, providers to support people in treatments, getting connected to healthcare across this nation. And there really needs to be a coordinated policy, not only at a national level, but at a state level. So I think about those kinds of levels of interventions, particularly in relationship to Marsha's story. And I do wonder, just because coming from Milwaukee and knowing a lot of those neighborhoods, like I really wonder what role gun violence had in Marsha's life. Particularly as a child, particularly as she pursued substance use and sex work and so forth. And the fact that there's many areas within Milwaukee that are highly segregated and highly high levels of violence in the community and so forth. So I guess I was kind of wondering about those aspects. And I think that's getting into the policy of redlining and the effects, as well as kind of what happened after the war. There was a lot of investment in suburbs and disinvestment in cities, and the white flight from cities. And I know that because my parents left Milwaukee and so forth. So I think about those kind of policy aspects that also have a role.
Yep. Yeah, and I think thinking about both what Erin was talking about and what Jessica was talking about, I think this is a really good example of how we need multiple levels of intervention, right? Because Erin's son needs a good schooling environment, right? And so we need to work at that level, right? Whether that's within the specific school or with a particular teacher or whatever that is, right? That's really important. And at the same time that we're working at these bigger policy levels that Jessica is talking about, and that could potentially impact maybe not Erin's son, it might take too long, but another child in the future, right? If we change the structure of the schools so that they are more supportive for students who are experiencing whatever kind of struggles they're experiencing, that might take longer, right? But so I think those are both really good examples of why we want to think about working at multiple levels simultaneously. That might not mean that one person needs to work at all of those levels simultaneously, but that we have communities that are doing that, right?
I can add something that Jessica said and something that Erin said. About 2 months ago, Marcia's oldest son was driving on the highway, the freeway, and was shot in the head.
In Milwaukee.
In Milwaukee. Okay, things have not gotten better, obviously. And Erin, something you said, and I'm bringing it back to substance use. And this is especially true for women because of the sexual abuse that is often the precursor. The fact that we do not integrate mental health and substance abuse right from the top. SAMHSA separates the two. The way the block grant money comes down is separated. And yet I've yet to meet anyone that I have treated who doesn't have a co-occurring mental health and substance use disorder. That comes back to how the insurance companies work, because you can't bill for mental health and bill for substance use. You got to give somebody one diagnosis, on and on and on. So from an institutional level, the integration of those two is something that is very important.
Yeah, thank you for that. So how about other people who haven't had a chance to contribute yet? Did you have any ideas, any of the levels of intervention kind of either particularly resonate with you given the kind of work that you do, or are there things maybe that you're already doing that are good examples of what we could maybe more collectively do as a community? Anything like that you want to?
I'd like to share a little bit what I've been doing.
Great.
So my name is Ariel Amendola. I'm a social worker. I work for the Las Cruces Public Schools as a staff wellness specialist. And I've been really trying to just normalize mental health and all of these topics that we're talking about: substance abuse, poverty, social issues. And since I serve such a large population and I have a good team behind me, I've been putting out a newsletter every month, and I talk about these areas. And I also talk about health too, because that's kind of like the role that I'm in. They want, when I first started out, it sounded like they were just focusing on health, but my lens is very much mental, physical, and emotional well-being. So I incorporate all those elements in the newsletter that I put out. And, I put like communication skills examples and like word starters and sentences. And I put links in there, and we partner with Downtown Desert Yoga, who offers yoga. So we give free yoga to staff. And we have the Calm app, so it has meditation. So we have a great team here trying to just incorporate so many different resources. And of course, our employees are the community. And we are seeing a lot of mental health problems, substance use. And I feel like if we just continue to talk about this, bringing this attention through the newsletter, through the presentations I do, through my supervisors, communication with principals, and how, we need to take care of each other. It's not just the staff, it's not just the students. We're all here in this together. And that's just kind of my goal that I've been trying to incorporate in my team's goal. And sometimes I feel like I'm not doing anything. Feels like I'm not doing much, but I have been getting some feedback, and the few emails that I get and the participation that we've been seeing, it you know, it helps us switch that feeling of hopelessness. So I think communication is really important. Like we said, the interpersonal communication is really important. I recognize the privileges I have. I'm Mexican American and Italian American, so I read possibly white to some people, I read mixed to some people, I have a higher education, so I take into consideration how I show up into a space. I use language that connects me to those cultures because I've lived here in Las Cruces. So I think it's just important to be really intentional. And I've been trying to learn the resources in town, which has been really difficult, even as a professional. Then I feel like I'm talking too much, but I get really nervous sometimes and I lose my breath. But so that's few of the things that I've been trying to do, and I'm just so happy to be in this. Sorry, that's my light sensor. I'm so happy to be in this presentation because it's very uplifting.
Great, thank you. You know, I think you brought up something that I didn't mention in this talk, and actually never have, that I think is also really, really important, which is this idea about providing support for other people in our community who are doing this work, right? And so I think, you know, being able to make sure, and that's maybe at that kind of institutional level or clinical level if you're working in a clinic, to really make sure that the work environment, and first of all, the work environment is one that's supportive, but then also that you're providing resources, right? So you mentioned two specific ones, offering free yoga and the Calm app, so that people can restore themselves, right? Because this is hard when you're doing this. So I think it just made me think about that. So I thank you for that, for your comments. And there's all kinds of other things that you're doing too in everything that you said. So all right, let's move on to that second question. What makes it difficult? What makes it hard to do the things that you all are talking about as interventions? What challenges do you face?
I would say one of the main challenges has a lot to do on the policy level as far as whether an insurance is accepted or not. Sometimes a lot of the resources available, especially for substance use disorders when trying to access medical assisted treatment, is whether or not you have insurance. And a lot of the times, if you don't have insurance, you have to pay out of pocket, and it can be very expensive, especially for those on the poverty line.
Mm-hmm. Yeah, so actually making sure people have access to resources. So those insurance barriers are really huge. Yeah. What else makes it hard?
When I think about us here in New Mexico, sort of our community, I think more of like culturally, like I grew up in a Mexican immigrant household. What we perceived as stigmatizing and a lot of let's sweep it under the rug type of ideology within my family that, you know, I try really hard to know we're not going to do that. I'm going to talk about it. And it sometimes gets to the point where my family tells me that I'm too aggressive and I'm too like high maintenance because I address these things. And through, you know, working with like a life coach and stuff like that, I've realized that no, I'm setting boundaries, I'm putting my foot down and speaking up. And where my family and, you know, my culture sees it as like you're being too loud, you need to settle down. It's actually me standing up and advocating for myself. And also really, so when I think about, you know, my community down, especially I grew up in rural Doña Ana County, you know, the Hispanic Latino population, how our culture perceives mental health, substance use disorder. And also when we're talking about the undocumented population and, you know, the lack of resources, I guess it's both community and policy, you know, undocumented individuals who were where can they find resources, the fear of finding resources because they believe they're a phone call away from deportation, from being arrested, you know, so I mean, I was an intern at La Casa's domestic violence shelter, and the amount of women that, you know, thought that if they called for help meant that their whole family would be deported and didn't know the policy and laws that would protect them and their children from deportation and would help them, you know, be able to separate from their partner in a safe manner and all these resources. So that's how I see from my family, my culture. And I mean, but when we think about New Mexico, there's like so much more that revolves around that.
Yeah, thank you. Yeah, those are all, you know, really good points. We do, you know, cultural backgrounds can certainly play a role in the perspectives that we have or that our families have. And then also, you know, you want to feel a sense of belonging in your own community. And so if it feels like you're doing things that are kind of outside the norm, that can be very challenging and a struggle. And then I think your point about undocumented individuals feeling hesitant to utilize services because of the fear of the very real fear of deportation, right? That's definitely a major challenge to being able to support people in getting the services that they need. Anything else? Barriers, things that make it challenging?
I wanted to jump in. You know, this just came up for me yesterday at my employer. You know, I work right now for a private company that's not very much grant funded, but we do have a couple of small grants. And I do have a small grant with Department of Health. And it turns out that because I'm grant funded, I'm not allowed to lobby. And the definition of lobby being to like ask people to vote, you know, a particular way on particular legislation, which is a huge policy problem because to act like that is not like an issue, you know, and especially, I mean, all of us with the UP Coalition, right? We are not allowed to, you know, to say vote for this, you know, right? Or so we can write op-eds and like we can do other things around policy, but, you know, a lot of it is law, right? And then the other thing that I think is also really challenging for me is getting into disagreements with my cohort about like what policies best serve the health of the substance use population, right? So one of the things that's happening right now is there's a lot of push and advocacy by the DEA and others around, you know, increasing, what do you call it? Punishment, whatever for fentanyl, right? So that like people that are convicted of dealing fentanyl may be charged with murder, right? This emphasis on making it like a weapon of mass destruction, you know, making the consequences much greater. We know that that is very bad for public health, right? And like this, you know, I mean, I'll speak for myself, right? I know that from my research and my study, right? And, you know, so arguing for increased incarceration and increased penalties, right? And then, you know, people feeling like, and totally understandably, right? Especially if you've lost somebody to fentanyl, you know, you want to see somebody get punished, but understanding all of these structural determinants and how they work, and that actually allocating more resources to punishment and increasing those penalties isn't going to help. And so, you know, getting into these kind of discussions about like what's best, right? And then you're like arguing with your colleagues, you know, and you know, trying to do that from a place of like respect and, you know, understanding. And so that can be really, really challenging. I think that yeah, anyway, I'll stop there. Thanks.
Thank
So,
you.
Another barrier, I guess, is what we're talking about. Things that make it difficult to intervene is something we've actually alluded to already, is stigma and all the different levels of stigma. I mean, there's stigma in the providers how they think about, for example, people with substance use disorders, the idea of trying to get more providers to do medication for opioid use disorder. Stigma is part of that. There's the internalized stigma, some of which Jessica mentioned, which is cultural and what people think about themselves who develop substance use issues or have mental health issues that they struggle with. And then there's the sort of institutional stigma, which was the redlining that you talked about before, and how the silos that Francine talked about in terms of the way money comes and how difficult it is to do holistic treatment of people. So stigma is a huge issue here, which is very difficult to overcome and address. It takes time and effort and education and a variety of, there's ways to do it, but it just takes an investment.
Yeah, thank you for that. I think that's a really important point. Before we move to our last question, anyone who has not yet had an opportunity to participate, I just want to open it up to you all to be able to add any challenges either that you faced or that you can see might be challenges for people trying to do these interventions that we've been talking about. Okay, so we'll move on to the last question. Please, if you think of something, feel free to put it in the chat or just jump in, and we can always go back to a previous question. So given that those are challenges, I think one of the things that's really, and actually I want to read what Jessica wrote in the chat before she jumped off, because I think this is a really good transition into this last question. She said, I always think of the difficulties as an opportunity. However, on a policy intervention level, it takes time to relationship build and plan with leaders and elected officials, and to move to a place with transformative policy change that places equity and community in the center of policy. And I think, it's important to keep in mind, some of the interventions may be things we can do today, right? Do this training, right? It can be something we can do today, and that's good, right? It's important to be able to take those quicker steps that will lead to change that matters to people, right? But some of these things are going to take a while. And so I think keeping that in mind is really important. But the other thing, and I think I want to, end our group discussion thinking about strengths. So what resources and strengths do either you have, does your organization have, does our community have, that you could start thinking about utilizing to maybe either address some of these barriers or to get started on some of these interventions that you all have talked about?
I think when I kind of think of this question, I'm sure we'll discuss it a little in a few minutes, but when I think about our coalition as a whole, we have our, I was kind of thinking of it, the community intervention. We have this coalition where we try to recruit all 12 sectors of the community. I know we don't have a full 12 sectors, but that's something that we consistently work on. But we have like this leadership team, this core team, and we have organizations that work with insurance. We have we have school representatives, like Ariel, who's with the public schools, and we have other people who work with military families, with tribal communities. Athena with Ideal Options, she brings a lot of different perspective to us. We have like government agencies, we do have like the partners with the DEA. So I think really just, that's like, to me, our coalition is like one of my resources. When I don't know something, I have this community that I can reach out to and find answers. And in turn, I can also, I try to, offer myself as a resource as well. If I'm let me try to help find you an answer or somebody to connect you with.
Thank you. Yeah, that kind of coalition work you can find resources and also just that community of support that you might need, right? To to get started on some of these things that can be really hard, or continue on some of these things that might be hard. What else? What other
Having the
strengths,
conversations.
resources?
I mean, 20 years ago, we did not have these conversations about equity and racism and those kind of things, similar to, Jessica, in terms of cultural. I mean, English is my second language. So, we're defining things, we're having conversations, we're putting tools and structures and steps to how to avoid, the things that didn't happen overnight. Those of us that have been, part of that or at the other end, they've happened. It's just that now we're calling it and defining things and putting a plan in place, which ultimately, whatever you can do at the community level or with our field, at least we have a name to it so that we can, put a plan and, slowly, in this work, see those changes, because they're not going to happen overnight. It's just that, at least in my role being that squeaky wheel, that we cannot forget whoever doesn't have a voice. So it's just having the conversation.
Great. Yeah, so maybe that, one strength is just that you have so many people who are willing to engage in that conversation right now is a real strength. Yeah.
Hi, I'm Mary Ellen Hernandez, and I'm from El Paso, Texas, with the Border Substance Abuse Council. I've known many of you over these years. The UP Coalition is amazing. I have kind of fell off the earth for a little bit, but I'm back on board. But everything Christina is saying, I've partnered with Christina for over 20 years. We started way back then, and exactly these conversations never took place. We didn't know what to call it. And so I think from all of your trainings, I have learned so much. This has been an eye-opener of many things that I think can be done. Baby steps, as always. We always do baby steps. And I just want to commend you all for the wonderful work you do, and looking forward to more partnerships. And yes, within your own coalition are the best resources always. I had a drug-free communities grant also for 10 years, and that is the best place. So thank you all for everything you do. And thank you for this training. I appreciate it.
I just want to point out that just to jump in real quick, that I think just to add to what people are saying, we weren't having those conversations in like what do you call something that's not the fringe, mainstream spaces, right? The Black Panther Party was having these conversations, right? And are now widely recognized as, a public health, the public health interventions that they did, right? Providing free lunches to children. They were talking about structural racism, right? But it was considered very extremely radical, right? And especially when we think about the lengths that the government went to shut that down, like COINTELPRO, and right, like that was really not welcomed, at that time. So yeah, I think the fact that we're having these conversations now in mainstream spaces, right, is so cool and important. Yeah, I think, Christina, if we had that conversation 20 years ago in that space, we would have been branded as like radical weirdos, right? So
Be in jail.
Yeah, we'd be in jail.
But that also brings up another important resource, which is our own histories, right? And the community organizations whose work has come before, what we're doing now, and being able to learn from the work that has been done before. That can be a really important resource. So whether, the Black Panther Party or other social movements, current and past social movements, can teach us a lot. So thank you for sharing that. Any other strengths or resources?
Well, again, I feel like I've talked a lot today, and I want to give other people a chance. However, I think there's actually a lot of resources available here. They're not all organized well, and they don't all always talk to each other. I think of the Resilience Leaders, which is another organization that is working to organize a whole variety of things on a number of levels. But my own personal experience here is I can write op-eds and information and have stuff published in the papers. I know who my local politicians are. I can talk with them, and I've presented information at the city council meeting, which has affected public policy. So, I mean, if you're thinking at a larger level, I think there are if not resources, at least openings or availability, or people are willing to chat with you, because around here, every single vote counts, as we know from our recent experience. So I think there are resources, and I think that people are really committed who are into this. There's a lot of energy behind this. If we could figure out a way for us to talk better. I mean, I don't think there's resistance. I think it's just not organized right now. Anyway.
I think it's a great point. I mean, I think recognizing, one, that resources exist and there's some work that we need to do, but also that there's incredible commitment, right? That's a huge strength, right? That we can use to build on this work. Let me just, again, one more time for people who haven't had a chance to speak yet, would anybody like to contribute either to this current conversation or the previous two questions? Just want to make sure everybody has an opportunity to either put something in the chat or unmute and give us your thoughts.
This is Valentina. I tried to avoid to speak just because I got sick and my voice is out, but it's fine. But no, I think I just wanted to piggyback off of what Jessica had said earlier about the cultural aspect of it. And I think cultural competency is very important, especially if we're trying to tackle interpersonal. And so along with that, I've worked about 5 years within the military community. And so that also has a lot of stigma around healthcare, coming off of what Ned was saying, a lot of things being stigmatized, thinking that regular civilian people like ourselves kind of assume that the military people have all of the access and all of their healthcare is free, which is completely inaccurate. We have homeless, service members currently right now. We have homeless veterans. And so, that is something that currently in my role, just being a private consultant at the current moment, just trying to tackle suicide prevention and try to, communicate with all of you guys and other individuals in the community that veteran service members, even Hispanic, Latino, Native American community, they all have these barriers and challenges that need to be communicated appropriately. Just to piggyback again off of what Christina was saying, just having the conversation. And so I think a lot of you guys had wonderful things to say, and I agree with every single one of you guys. So I'm so happy that you were here, Mary, to give this presentation, and I learned a lot and continue to learn a lot, especially being a part of the UP Coalition. So thank you guys.
Thank you, Valentina. I think you make, really good points, right? That there's sometimes we can make assumptions about who our communities are and what impacts different communities. But and then I think part of the strength of a coalition is being able to learn, like from you, about what are the challenges that service members and veterans face that other people who aren't in that community might not understand. And so I think thank you for sharing that. Well, I do want to give you all a chance in these last few minutes to kind of talk through where do you go from here? What are the next steps for your coalition? How do you take this training beyond today, right? Because I think that's one of the things that is that sometimes happens, right? We can get some more knowledge from a training, but then tomorrow happens, right? And so I wanted to give you all an opportunity to kind of talk about where do you go from here? What are the next steps? And I'm, as you all are talking, I'm going to put a couple of resources in the chat from the about structural competency in case you want to learn more about it. And also just say thank you so much for inviting me to do this presentation. As usual, I think I learned as much from you all as I'm able to teach. So so I really appreciate you, and thank you so much for sharing your perspectives and your experiences and your stories today. But I'll turn it over to the UP Coalition to close it out.
So thank you so much, Dr. Scott, for coming. I know that I was really excited about you presenting on this to the coalition, and this came out of a I think it actually came out of our survey, right, Christina, regarding you know, areas where we as a coalition felt like there might be some things that were lacking. And one of the things that we felt was lacking was knowledge about health equity and sort of, you know, folding that into the material of the coalition. And so, you know, for myself, I'm always interested in, you know, I think there's a lot of ways, you know, they're different concepts, but somewhat the same, right? The health impact pyramid, structural competency, you know, health equity, you know, social determinants of health, right? So thinking about as the coalition moves for health at all policies, right? So thinking as the coalition moves forward about, you know, in things that we choose to tackle and the ways that we choose to approach it, having that health equity lens, you know, to see through. And also for ourselves, I think it's really helpful because we have to do a bunch of paperwork, you know, justifying our funding and like what we spent the funding on, right? And so the more that we know about health equity, the more that we're able to justify to the funders why the things that we're choosing to do are actually in line with the goals that we've been set out to tackle, right? Sometimes it's hard if you don't have the understanding to make a you know, an inference between like an anti-poverty initiative and like lack of substance use in a community, right? Or like things like ACEs, you know, adverse childhood experiences. If we want to take that on, you know, we'll be through trainings like this more easily able to justify why that's in line with our mission and our vision. So that's like for me what I'd like to see moving forward. As a member of the leadership team. And thanks again, Dr. Scott, for coming and starting us off on this conversation. I hope it's like the beginning of a thing.
I also want to say thank you for this training today and thank you for the presentation. I also feel that moving forward, someone had mentioned that even though we have a lot of resources, a lot of the organizations aren't talking to each other. So I think when we have these trainings, it's a great opportunity to network and be able to share those resources.
So thinking about this from sort of a, trying to make this a little bit more practical, I guess, and piggybacking on what Athena just said. As we move forward with our work on the coalition through our committees, I wonder if we can somehow or other make sure that this lens is included in the conversations going forward. So at what level of intervention is this particular decision we're making going to approach or attack or somehow or other try to change? And how does health equity fit into what we're going to be saying? Also, I think if we use the same lens when we write our grants from now on, we need to build in this perspective as well. And somehow, I mean, I'm not sure exactly how that would be done yet, and the staff know much more about that, or at least we'll be able to think about it more more than I can right now. But I think we need to use that as sort of an overlay as well as we move forward and think about what it is we're how we're moving forward in our grants. I think it ought to be part of our, somehow built into our agendas for our meetings, to remind people that this is now part of our thinking and how do we want to use this.
I completely agree with you, Ned. And I just saw Athena's, I mean, not Athena, Valentina's comment as well about integrating the levels of intervention into our work groups. And I can definitely see that being a very important, topic that we discuss. And I mean, we have our coalition meeting next week as well. So probably recapping a little bit about what we learned today in that group as well. And I really appreciate, you, Mary, being able to provide this for us. And I'm looking at, level of intervention on the policy and research level, and how I'm already kind of thinking of how we can, now that I've learned that, and expanding maybe our advocacy committee, where I feel like we've sort of, I personally feel, I'm not sure how everybody else feels, but we kind of fell off. It was kind of didn't really know what we were doing in that committee. It was to the point where we only had basically one task in there. And now that if we go back and maybe think about it on these intervention levels, how that maybe now there is more that we can think about in that specific committee on how we can expand it and start moving work forward, because that's where maybe that was one of our weaker committees. But maybe if we integrate more of these levels of intervention into that committee, we can start expanding it more and more. I don't know how the other leadership team members feel about that, but that's kind of where my thinking is going.
I think trainings like this do exactly that ideally, right? Like reframe your thinking and like reinvigorate, what you're doing, and think about different ways that, so yeah, I think that's like exactly how I feel after a good training. Oh, look, Lisa.
If I can just comment. Can you guys hear me?
Yes.
Okay, I'm Lisa Jenkins from the Public Defender. And in terms of early intervention, what we did was we reached out, our social worker and I, to the Doñana County Misdemeanor Compliance Program to let them know to reach out to us when they see clients aren't complying, so that we can get involved earlier instead of, automatically violating them, or after their rule of, 3, whatever violations, we're going to violate you. So I thought exactly what you guys were saying, we did this week. And so I want to be more allies with them instead of opponents, because we're all helping the community here. So thank you guys for this training.
And you should come and join our coalition.
Yes.
Okay.
Thank you, Lisa. Yeah, I think that's another thing that we, as a coalition, and personally being involved in the UP coalition, we try so hard is to like knock down those silos, and like, we're in this together. We work together. There's no competing. There's no like, oh, like I get paid for this, I should be doing this. It's like, no, like we're here to help each other. If we can do it together, we can do it together. If we can fill in the gap, if somebody else can fill in the gap where maybe we're not able to, or if it's out of our expertise, like we should be allowed to reach out and find those other people and resources and things like that. So I know that's something that we take a lot of pride in as the coalition, is like, we absolutely are not siloing. It's why we're part of so many other committees, why we're part of so many other organizational efforts as well, is because we understand the importance of, our county is so big, we don't have that luxury. We need to knock them down, and we need to work together.
I wonder if one of the things we can do, I'm looking at the time and I know we need to stop, but I wonder if one of the things we can also do is encourage all of the coalition members to watch this video. there were a lot of people that weren't here today for a variety of reasons. And we want to begin to help people think about the stuff that we've learned about today. And so we should make it available, encourage people who are members, anybody who is new that joins, along with the orientation that we give them. We might want to make this part of the orientation as well.
Right. I think we're pretty much at time. So thank you all again so much for participating and for inviting me to have a conversation with you all today. It was a great way to spend a Thursday morning. So I appreciate it. And I did put my email, if you all saw, I put my email in the chat. Please feel free to reach out and at any time. And if you are interested, I'll just put a plug in for the online course that we created. It's free. And it's in the pilot phase right now. We just finished it. And so if you're interested in reviewing it, I would be happy to send you a link. But thank you again.
Thank you.
All right. Bye,
Thank
everyone.
you so much, Dr. Scott.
Thank you.
Bye-bye.
Bye. Appreciate everybody. We're better together.